Continuing on with Unit 2, A and B, Objective 15, examine the reality of conflict in the environment of the nurse. Conflict isn't every day. It is tension that arises when the action of one person frustrates the ability of another to achieve a goal. Conflict can never be eliminated, but can be managed, and that's something as nurses we need to strive for is conflict management. It can take place between individual nurses. Conflict can be within a unit. Conflict can be within a department. It can be inter-unit, interdepartmental, etc., and etc., and etc. There are three types of conflict. Individual conflict. The most common type of conflict involves role conflict within the individual. You have conflict with yourself. Should you go to work today or should you call in sick because you don't feel good? But if you call in sick, then you're hurting your other nurses that you work with. It's individual conflict. Interpersonal conflict occurs between two people. This is probably the most common thing that we think about with conflict is two individuals just don't get along for some reason or another. Conflict can also be intergroup or organizational conflict. And again, this is conflict that occurs between two groups. So say you have a group of med-surg nurses that start to have conflict with the mental health nurses. Or you have the nursing department that has a conflict with the physical therapy department. That would be intergroup or organizational conflict. Conflict can be either overt or covert. Overt conflict is when the individuals or group members address the conflict openly. This allows coping to be easier and is easier to accept that a conflict is occurring and add a description of the conflict. Overt conflict is probably the healthier way to deal with conflict. We can also have covert conflict. This is when the conflict is not addressed openly. The conflict is exhibited in reactive, repressive, or avoidant behaviors by the individuals involved in the conflict. Covert conflict actually increases stress, distress, and confusion among the members that are experiencing the conflict. There are many different causes of conflict. They can be from inadequate communication, incorrect facts, a lack of trust among healthcare providers, unclear position descriptions, a misunderstanding of roles and responsibilities, unclear or conflicted goals and objectives, an inadequate action plan, directions that are not clear-cut, unstable leadership, receiving direction from two or more bosses, an inability to accept change, lack of leadership, lack of or limited staff participation in the decision-making process, or if there are power issues among the unit. All of these things can cause conflict. There are some strategies to help prevent conflict. These include very clear communication where the sender makes sure that the receiver is getting the correct message. Understanding, recognizing the causes of conflict, especially common causes in nursing. Understanding that they are common causes of conflicts and how to recognize them. A clear understanding of the roles and responsibilities of the individuals that are working. With nurses, which nurse is going to be doing what. Do you have aides on the floor? What is going to be the job of the aides? What is the job of the unit secretary? What is the job of the radiology tech? What is the job of lab? Having those very clearly defined roles and responsibilities help decrease conflict. Allocating resources fairly also help prevent conflict. If you have one floor that has 3 patients to every nurse, it's really important that the resources on another floor would have about the same resources or have a 1 to 3 staffing ratio. By having resources allocated fairly, you're less likely to have conflict. Having clearly stated expectations from those that are working also helps prevent conflict. Avoiding any sudden unexplained changes in processes, addressing staff fears, and identifying any potential barriers to conflict resolution all help prevent conflict. Preventing and responding to conflict. It is really important to deal with conflicts as they occur, and that kind of basically decreases the fire before it turns into an inferno. Nurses should avoid behaviors that lead them to defensiveness or counteractions. Nobody is perfect. Listen to the individual that is having a problem or trying to explain something to you. Observe nonverbal communication. Remember, 85% of what we say isn't actually coming from our lips, but it's coming from the actions in our nonverbal communication. Treat others with respect. Try to avoid arguments if all possible. Allow time for individuals to vent as long as it takes place privately and done appropriately. Listen to each other. We have 2 ears and 1 mouth for a reason. As nurses, we should be listening to our patients and our patients' needs. Consider the other person's point of view and consider the phases of conflict resolution when we are trying to prevent and responding to conflict. Typical responses to conflict include avoidance. This is where a person withdraws from a stressful situation due to the extreme levels of discomfort and inability to cope. This can be a positive or negative approach to conflict resolution. Accommodation is another response to conflict. It is trying to make a situation better by cooperating with the individual in which the conflict is occurring. This is typically a negative approach. Competition is another response to conflict. This is where power is used to stop the conflict. Again, it's usually a negative approach. The last response to conflict is collaboration. This is usually a positive approach. The parties involved try to reach an acceptable solution together, and it often involves compromise from both of the parties or how many parties are involved. They have to work together in order to create a solution together. Objective 15 says contrast the 3 different styles of communication and their impact on clients and healthcare team relationships. Aggressive communications and communicators. Their aggressive communicators focus primarily on their own needs, not the patient's needs, and become impatient when their needs are not satisfied. Passive communicators focus primarily on the needs of others and often deny themselves power, which cause frustration within those individuals. Assertive communicators are able to declare and affirm their opinions while respecting the rights of others to do the same. It is a balance between aggressive communication and passive communication. These individuals express themselves effectively and stand up for their beliefs while still respecting the rights of the other members of the group. Techniques for assertive communication include using I statements, fogging, negative assertion, repetition, confidence. They manage their nonverbal communication so it matches their verbal communication. They think before they speak. They avoid apologizing whenever possible, and they perform a post-conversation evaluation. Objective 16 says explain the different types and purpose of nurse reporting. Nurse reporting can be at a change of shift reports. Change of shift reports can be at the bedside. They can be taped reports, or it can be an abnormal only report. Telephone reports is another way that nurses report. Usually when we use telephone reports, we're usually notifying the physician of a change in the client's condition or of abnormal laboratory results, or if we're going to transfer the patient, and it must be documented. Care plan conferences are collaborative care. It again is a type of nurse reporting, and it must include all the vital components of the collaboration, and again it needs to be patient-centered or client-centered. Nursing rounds. Nursing rounds is another type of nursing report. There are 2 or more nurses report to each other and the client at the bedside. Again, typically it's bedside reporting. Objective 17 says discuss the process of various provider orders and the RN's responsibility. Some different types of orders include standing orders, written orders, telephone orders, and when we know orders. Standing orders are orders that we need to make sure they are followed for each patient that has them. For example, when a patient goes to surgery and is going to have an appendectomy, almost all appendectomy patients have the same order set, and those are standing orders from the physician doing the appendectomy. Written orders. With the written orders, we need to make sure that the cardex is updated and the new orders are passed along to the oncoming shifts. We also have to ensure that all the new orders are being followed and are being completed by the nurse. Telephone orders. This is where you write down the order and you read it back for accuracy. Then you transcribe it to the physician's order sheets. It's either a verbal order read back or a telephone order read back by the physician and then / your name as an RN. Noting orders is something that RNs need to do. This is done to make sure that the entries by the physician are entered into the computer, and we need to make sure that everything is updated and the patient is aware of any new orders. Then we sign off that the information is correctly entered and it becomes part of the medical record. Now with computer physician order entry, or CPOE, typically we note orders when we go in and acknowledge them. Acknowledging an order is basically the old form of noting an order. So again, most physicians now are actually using a CPOE, or a computer system, where they put in the orders themselves. We as nurses go in and acknowledge those orders, basically saying that yes, we've seen them, yes, we're going to follow them, and we need to make sure we update the patient on those orders, and then also that we are completing those orders as directed by the physician.